to introduce a study that I did using formulary files. So again, this is a study about new hepatitis C drugs, which we discussed yesterday. So in summary, formulary file gives you information about drugs covered by Part D plans. So it tries to capture the entire universe of Part D drugs. It's not really entire. There are some PDE records that's not really captured in formulary files. And not only just a list of drugs, it gives us information on tier assignment and utilization management, which is again, this captures a sort of a benefit generosity of Part D drugs covered by the plan. So if you are working on 2006 through 2009 data, there are public files are available, public formulary files are available for these years, but for research identifiable files, that formulary files are available since 2010. So before 2010, what happened was that they added formulary information to PDE file. So if you acquire 2006 through 2009 PDE file, you receive variable of tier ID and quantity limits and prior authorization, etc., in PDE file. And you don't get to see those variables in PDE since 2010. So now then what you might ask, oh, why do you, I mean, would it be more convenient to just have this formulary information in PDE file? Why do they separate out? So when we have this currently formulary files are the formulary file itself is a complete or a standalone file. So it covers all not all, almost all Part D drugs are covered by a plan. However, if we add this information to PDE file, you can get to see formulary information only for drugs used by your study sample, not just even entire beneficiary. But if you request only 5% sample, you just get to see the formulary information for the drugs that used by the 5% file. And if you have sample the patient with diabetes, for example, then you may not get to see the formulary information on cancer drugs if a diabetes patient didn't use any cancer drugs, right? So this is somewhat limited because we didn't have any information on drugs not used by your study, the research the study sample. So it was pretty exciting when I got to know this, that from 2010 this formulary files will be available as a standalone file. So I was thinking, how can I use these formulary files? So again, this is a separate file that you have to request. Then you have to think, do I need a formulary file? And in other words, do I want to request a formulary file? And if so, why? And how am I going to use the formulary file? So the first thing, you can link a formulary file to plan characteristics file, and then you can examine whether the use of utilization management tools, it differs across the different plan types, right? You can compare MAPD, MPDPs, the medical report or any tables that Stephanie showed in earlier section. It's all they are based on formulary file and the plan characteristics file. And also you can see the variation in tier placement and cost sharing across the different plan types. But this is a small note here. Formulary files are not, they do not depend on DUA. So these are the same for all researchers. And it's it's not really limited to plans that serve beneficiaries in your study sample. And also you can link formulary files to PDE files. Now then you can examine the association between the use of any utilization management and drug utilization. So let's suppose a plan imposes the prior authorization. Does it really prevent beneficiaries from using the specific drugs? And that's an interesting question. Or if you are not interested in any of the utilization management, the tools per se, then you can simply use these variables as covariates in your regression model. So that's another way to use a formulary file. So now I'm going to introduce this the one study that I did using formulary files. So just again, to summarize this Hep C drugs, I'm looking at Hep C drugs, the new hepatitis C drugs like Sovaldi. So these are very effective and expensive drugs. And was first the drug was Sovaldi, and that was introduced in December 2013 with a list price of $1,000 per pill. Now in 2014, two competing competitors came into market. The two additional drugs, Harvoni and Bikirapag, entered the market. But while we expected that with more competition, the price might go down, but it didn't. So they actually, Harvoni and Bikirapag, they almost charge the same prices, about $1,000 per pill. So given this high cost, payers, the insurance company, not just the Medicare Part D plans, but commercial insurers as well, and they charge the high cost sharing to consumers for these new Hep C drugs. So these new, and now we are, this is now 2024, right? Pretty comfortable with, the price tags that cost like even $100,000, but that was 2013. This, the total cost of treatment, $84,000, was really high. It's huge. It's eye-popping numbers. And then there was a newspaper article almost every day or every week is talking about these new Hep C drugs. And they said, why is this really we want to pay for these innovative drugs? So reading these news articles, and I was thinking, oh, really? Then let's see then whether these Part D plans actually cover, they put these new Hep C drugs in their formularies, right? And these are really expensive, right? If so, then how much cost sharing do they charge? Right, so in Part D plans. So I wanted to look at in 2015 data. So outcome measures, so it's just simply just examining the coverage, the benefit generosity for these new Hep C drugs across the Part D plans. So I came up with a couple of outcome measures. This is not real regression, it's just some descriptive data on the interesting outcomes. So the first outcome variable that I was interested in was percent of Part D plans that placed a specific Hep C drugs in specialty tier. And second outcome measure is a percent of plans that apply the prior authorization or quantity limit. These are utilization management tools to each specific Hep C drugs. And then I wanted to calculate average out-of-pocket spending that's required to complete course of treatment. So I did this exercise separately for PDPs and MAPDs. Right. So this is my research question, or you can simply say, think this is a research of the outcome measures. What data would you request? So if we wanted to say, okay, let's suppose this is your study, what data would you request to answer these questions? Plan characteristics part, yes. And anything else? Do we need only plan characteristics file? Let's see, I'm going to go back to the previous slide. So these are the ones that you want to measure, right? So the Part D plan uses a specialty tier for each Hep C drugs, a formulary file. Exactly. So do we need PDE files? Do we need the MBSF file to answer these questions? Probably not. These are really plan level information, and we are going to simply get the one summary statistic, right? So this is information about Part D plans. So we do not need any MBSF or PDE files. So all the data sets you need is just two. It's just the Part D plan formulary file in order to get information on tier assignment and use of utilization management tools. And then Part D plan characteristics file to get the plan type, PDP versus MAPD, and also get the cost sharing for each tier. What is step one? So now, okay, so I want to see whether what percent of plans place, let's say Sovaldi into the specialty tier, whether they use a specialty tier for Sovaldi or not. And I got this plan characteristics file and formulary file. And what's the first step? How would you study? We can do research it together. you can think loud. Any thoughts how to go about this? What would be the first step? So if you think about formulary file, let's see, formulary. Let's look at formulary file. This is what the Steve showed earlier. So it's you have a formulary ID and you have a formulary RX ID, which represent a drug, and then and whether and with tier information and which tier this drug belongs to, and then whether there is a quantity limit on this drug or not. And again, this is the universe of all Part D drugs, right? But are you interested in all the drugs? No, we are going to focus on only new Hep C drugs, and there were only three Hep C drugs in 2015: Sovaldi, Haroni, and Bicara, right? So what would be the first step? Plan characteristics file and formulary files are complete files, right? So that has all the complete information. So the first step would be you want to select, you don't have to use all the records in the formulary file. You want to probably select records of new Hep C drugs from formulary file, right? How? So in the formulary file, can you see here, there is a brand name. So we know brand name, right? Harmony, Sovaldi, Harmony, and Bikirapep. It's very easy because these are all new drugs. They are all no competitors on the patent, and there are three drugs that we are interested in. So using this brand name variable in formulary files, first just select the records on the new Hep C drugs, right? So and this is how it shows. So this formulary ID. Formulary ID is a formulary called 889, and this you see here, this is actual formulary RX ID, I believe so. I probably I'm not. I don't think I actually modified numbers. So these files, these formulary ID covered all three Hep C drugs, right? So under this formulary, all these drugs are covered, but this formulary, they place the Sovaldi and Harvoni into tier 3. We don't know what tier 3 is, but tier 3, and then they put Bikira in tier 4. The another formulary 888, and this formulary covered only Sovaldi and Harvoni. So this formulary did not cover Bikira. And this formulary put these two drugs into tier 4, right? And then we know that whether this, and this formulary didn't apply prior authorization for Sovaldi and Harmony, but they put prior authorization for only Bikira. And this formulary had prior authorization for both Sovaldi and Harmony, right? So, okay, so we selected all these records from formulary file. What is step 2? The first question, the first outcome measure that we wanted to get was the percent of plans that placed each Hep C drug into specialty tier. So, well, then is this, for this formulary, is this tier ID 3 is a specialty tier, or 4 is a specialty tier? And for this formulary, is a tier ID 4 is a specialty tier or not? That's what you have to figure out. You want to add here specialty tier information to this table so that you can count how many plans use the specialty tier for each Hep C drug, right? But there is where do we get the specialty tier information? Formulary file does not have tier the specialty tier information. Where it comes from? It comes from cost sharing tier file. Yes, join plan characteristics with the formulary file. So the next step is, in order to get information on specialty tier, we need to link this formulary file to plan characteristics file. So we're going to join. And Randy is correct. We're going to join. What is a link variable? How do you link this formulary file to plan characteristics file? Formulary file does not have a plan ID, contract ID. Can you see that? Right? So then what? So we have to know, we have to use a formulary ID. Formulary RX ID you may not want to use because formulary ID in formulary RX ID is not in plan characteristics file. So plan characteristics file shows in this contract plan what is a formulary ID that this plan use. So you have only formulary ID information in plan characteristics file. So again, each party plan has one formulary ID, but this ID is not unique to that plan because we have about 300 to 500 formularies across years, depending on year, but we have between 3,000 and 5,000 plans and depending on year, 1,000 plans depending on year. So you need to do actually many to many merge. But anyway, this is how it shows when after you linked formulary file to plan benefit base file. I first linked this one to plan benefit base file. I think benefit base file has specialty tier information probably. Now, so for this now contract ID, plan ID, because we did many to many, and we have for each formulary ID because we identified the 3 Hep C drugs. So this formulary ID had 3 Hep C drugs, right? All 3 Hep C drugs. So after merge, it shows like, okay, for this contract ID, contract plan, this formulary ID, formulary RX ID, and then this, you can see the drug names here. Now, next, we need to know specialty tier. Specialty tier information and cost sharing for each tier is actually in cost sharing tier file. So once you merge this to benefit base file, the next step is to link this one to cost sharing tier file, right? So in order to get the cost sharing and tier specialty information. So when you link this plan, it's a formulary plan disjoint, right? Plan characteristics and formulary joint file. You link this file to cost sharing tier file using contract ID, plan ID, and now tier ID, right? And then you can get cost sharing information for each tier. For tier 3, where Sovaldi is, what is cost sharing? And also there is a special tier variable in cost sharing. And if it says, because you use the tier ID as a linking variable, and tier 3, if a specialty tier variable says yes, that means that, oh, for that plan, tier 3 is a specialty tier. Then you know that the Sovaldi is in specialty tier, Havroni is in specialty tier, but Bikira is not. Right. So from cost sharing tier file, you get information on the specialty tier and cost sharing. Then what's the next step? Then we have a problem that all the information we need to produce the outcome measures we want to examine. So, and then the next step is you want to analyze record now drug by drug, because the question was for each drug, for each Hep C drugs, what percent of plans have a specialty tier, or what is the cost sharing, and etc. So when you get for each drug, you get just a simple, this is a summary statistic, right? So you get a percent of plans using specialty tier, using each management, the utilization management tools, and then you also get the co-insurance, and then you calculate the total out-of-pocket spending of the course of treatment, which is 12 weeks, right? So using this one, this is what I got. So you can see here and I did analysis separately for MAPD, MPDP, and for each drug. All MAPDs and all PDPs covered Sovaldi, right? But you can see here only 33% of MAPD and 30% of PDPs covered Bikirapec, right? And the prior authorization, once they covered, almost all plans use the prior authorization. Quantity limit is somewhat mixed between 40 to 60 or 80%. And over 95% of plans, almost all plans in PDPs, but 95% of the MAPDs, they use the specialty tier for each Hep C drugs. And they all use, almost all here, except a couple of plans, they all use the co-insurance instead of co-payment. So after this, that we calculate the total out-of-pocket spending. This is only among non-LIS enrollees because LIS enrollees, their co-payment is pretty low, so it's not really meaningful. So this is a total spending, and this is a consumer side, the out-of-pocket spending. On average, between MAPD and PDPs, it's going to cost a patient between $6,500 or $6,300 to about $7,200. So mean values are pretty similar. The first thing is the mean values are pretty similar across all three Hep C drugs. The second observation is between MAPD and PDP, who is more generous? So if you simply look at only mean values, you don't get to see much difference. It's pretty similar. Slightly higher in PDPs, but look at variation, look at range. So in maximum out-of-pocket to treat this, it goes to this about 6,900 or 7,000, but the lowest part, the lower bound is for MAPDs. Some patient might pay only $2,600 to use this complete this treatment. But in PDPs, there isn't much variation. This means that there are some really generous MAPD plans, right? So there are questions. So does the CMS require Part D plans to cover at least one Hep C drugs? I'm not sure whether there was 6 therapeutic classes that CMS required. That was no, not quite sure. In earlier, I know it's cancer is one of and there was some AIDS or some infectious disease, but not quite sure whether there was one of Hep C drug or not. And so, how did you get total spending? What do I mean by total spending? Total spending is total spending. I used this. What was the drug cost or total drug cost in PDE file? So for each plan. So each plan, you can get the total drug cost per pill, per prescription fill, right? Not just per pill. Per pill is $1,000, right? But if it's a 28 days, and then the cost is probably like a 28,000, and then you just summing up for 12 weeks of treatment. Total drug spending, right? Okay. Which file did you use to get the for drug cost? Oh no! Oh, I see now. I see what you mean. Maybe I did not answer the probably correctly here. That yes, I did not use. I'm sorry, I did not use PDF file. This is purely based on a formulary file and the formulary file and plan characteristics file. And I probably must have taken simply list the price. Right? Which file did you use for the drug cost per beneficiary? For beneficiary variables. I did not use beneficiary variables. This is based on the plan benefit scheme only. So in other words, we know that, for example, one drug actually put Sovaldi into specialty tier and cost sharing is 30%, then how could you calculate? So we know that for this 12 weeks of treatment, right? So 12 weeks of treatment it's 84 days, and then it's 84,000. You need 84,000, but if 30% of co-insurance, you simply multiply by 30%, and that's how you get. Does it make sense? So that's so it's just the using plan benefit information and cost share co-payment or co-insurance information, and then you have this list of price and then probably multiplied and then get this number. Right. And then so with this, you can actually apply this to similar drugs. So we did actually another one for the looking at to look at specialty cancer drugs. So there was a specialty drug. So now this drug called the Gleevec. Gleevec is leukemia treatment, and back in 2010 and 2012, this was on patent. So it was a brand name only. Current now it's there are generic drugs available, and this is one of very expensive drugs. And important is anemia treatment, again expensive drugs, and they were all specialty drugs. So and then for these two drugs, we also looked at how many plans used a specialty tier to cover each of these drugs, and plans that did not use a specialty tier, and you can see here more plans use the specialty tier to cover Gleevec and Epoetin. Still large number of plans use the specialty tier, but slightly fewer number of plans use the specialty tier to cover Epoetin compared with covering Gleevec. And also we calculate also the co-insurance. This is not to complete the course of a treatment. This is just the plans placing the drug in a specialty tier. So in just the cost sharing information for that specialty, for the plans that use the specialty tier to cover Gleevec. So on average, those plans that use the co-insurance, most of plans use the co-insurance for the specialty tier where the Gleevec was, and the co-insurance amount was mean value was 29.7%, and then minimum was 25%, and max was 33%. And it's surprisingly 4 plans used the copayment to cover Gleevec, and the mean copayment value was $75. And similarly, here those plans that did not use a specialty tier, some of them and most of them still use the co-insurance, and you hear that the mean and the max is really high. In other words, instead of using not using specialty tier, does not necessarily mean they have lower co-insurance, because they could use non-preferred brand name tier and place Gleevec there, and they could charge high cost sharing. And then again, some plans use copayment information. And similarly for Epoetin, those plans that use a specialty tier for Epoetin, all plans use the co-insurance, and co-insurance range between 25 and 33%, but no plans use the copayment. But when plans didn't use a specialty tier to cover Epoetin, and a lot of about 398, a little bit less than half of plans use the copayment as opposed to co-insurance. So okay, these so far I have looked at only descriptive data, but you can actually ask some research questions. Then, okay, now I want to look at link this formulary file or the information we can construct using formulary file and plan characteristics file, and link that files to PDE file, and then you can examine the relation between plan benefit generosity and drug utilization. So one question that I was trying to answer here was, okay, does cost sharing for specialty drugs really doesn't matter for the specialty drug utilization in Medicare Part D? So there was some competing hypothesis here. So some say that, well, think about it, specialty drugs are used to treat the really serious and debilitating, right? It's really life-threatening some conditions. Why would the cost sharing matter? Probably most of patients, if you have such serious conditions, you're going to use these drugs. Some say so, and some say that no, still, even though you have a cancer or Hep C, still cost sharing could be really prevent a patient from taking the necessary drugs. So we constructed this cost sharing for specialty cancer drugs. So we selected all the specialty cancer drugs, and then come up with some average or some summary measures of cost sharing, and whether that cost sharing for specialty cancer drugs matters initiating any specialty cancer drugs. And here you can see that as $100 for a $100 increase in copayment, the probability of using specialty drug decreased by about 6%. Based on the instrumental variable approach. But this is just the example that you can utilize once you pass through some descriptive data on the plan benefits for each drugs that you're interested in, and then you can examine actual medication utilization. Just in summary, formulary file contains information about drugs, Part D drugs covered by plans, and this captures some universe of Part D drugs or plan generosity. And also, this is my one final comment and why we want to use a formulary file or plan characteristics file. And this is a very unique file. And I have not seen any study and I have not heard any case where commercial plans release their drug formularies. It's a really rare opportunity that to get actual formulary files for drug plans. And so if you are interested in looking at cost sharing, use these formulary files to construct cost sharing measures. So studies tend to use simply PDE files or medication utilization files to come up with patient cost sharing. That's actual cost sharing. And then they use that as if they are cost sharing, and then they regress, okay, what's the impact of cost sharing on the drug utilization? But their cost sharing measures is coming from actual utilization, which was already affected by cost sharing information. So this is really, it's essentially if you are using actual patient pay amount from any PDE files or medication utilization claims that those variables are endogenous. So for Part D study, I really encourage to use a formulary files in order to get unbiased and exogenous cost sharing information in any drug research.